So what are some of the specific QI skills? We've looked at some of the system skills, but let's now focus a little bit more on the quality improvement skills that they'll need. Well, the first is they need to understand the key definition of what quality is. I gave you a definition of quality at the very beginning of this talk. And they also need to understand the Institute of Medicine rules for what quality is and what it is that we really need to take a look at with regard to quality domains. And I would strongly recommend that residents at least read the executive summary to the Crossing the Quality Chasm report from the Institute of Medicine almost 10 years ago now. As we mentioned earlier, they have to know how to measure quality, and that means using performance measures. We've talked a lot about microsystems, how important it is they understand that. But I also want to focus on two particular important process tools. Again, tools that will help them identify a problem within their microsystem with regards to quality, and then gives them a process on which to improve it. The first is the PDSA cycle, called the Plan, Do, Study, Act cycle. That was first really endorsed by a gentleman by the name of Walter Sheward way back in the 1930s, and then used by Edward Deming in Japan to help them recover from the Second World War. It only recently has been brought into medicine over the last 30 years and used effectively to help improve quality. And so residents really need to understand the Plan, Do, Study, Act cycle and how they can use it to improve care. Flowcharts are a simple technique that simply allow you to take a work process and then simply flowchart it out. Flowcharts give us an opportunity to look for where there might be bottlenecks, where there might be problems, or where things might create inefficiencies or create particular activities that might be unsafe for patients. So for example, if you have a patient who's on a blood thinner, such as warfarin, that needs to be monitored to make sure that the level of blood thinning is neither too high nor too low, who's going to track that within the clinic? Once a problem's identified, who's going to notify the patient? Flow charting can help you identify what the process is and look for opportunities to improve it to make sure the patient is safely being monitored. And then finally, they have to understand and apply basic safety principles and interventions, such as sign-out and handoffs. We'll come back to that as an example at the end. Residents also need to understand what the role of physician leadership actually is. Do they understand what a physician opinion leader and champion actually is? What are the characteristics? For example, research has shown that physician champions often have a strong sense of volunteerism and are actually very engaged in improving their microsystems. And so it's important that they understand that to be truly a leader, what are the important characteristics they're going to need to demonstrate in order to take on that role. We've talked a lot about interdisciplinary teams, and then as I said, they have to be able to institute change as part of a rapid cycle PDSA. What that simply means is that when you're trying to make a change, you don't necessarily have to do it as a large project. Sometimes a small change and studying it quickly through a Plan, Do, Study, Act cycle can be very helpful. And that's illustrated by the Donabedian model, which helps us think about what it is we want to measure. And this is also important for them to understand. And this is a nice, simple model when you're thinking about what it is you're trying to improve within the system. The first level is called structure, the way a healthcare system is set up and the conditions under which care is provided. An example of a structural measure would be, do you have an electronic medical record or not? That's part of the structure of a healthcare system. The second are what are called process measures. These are the activities that simply constitute healthcare. Was a diagnosis made? Was a treatment provided? Was prevention actually executed? Was education given to the patient, etc.? And we can measure whether or not these things are done, such as, was the hemoglobin A1C actually measured on this patient? Did the patient receive a mammogram? And did the patient receive diabetic counseling on how best to manage their diet? Those are all examples of process measures. Outcomes are what we're actually most interested in, and these are the changes, desired or undesired, in individuals that can be attributed to the health care they receive, such as change in health status. For example, if a patient receives an artificial hip, are they now more functional than they were before receiving that hip replacement? Change in knowledge among patients is also important. If they don't fully understand how to care for their diabetes, they're likely to be less successful in successfully managing that diabetes and avoiding complications. Change in patient behavior. The knowledge leads to hopefully changed behavior. And we'd want to know, for example, are they exercising more? That would be an important outcome. And patient satisfaction itself is also important. More satisfied patients are more likely to engage in their own healthcare. And so measuring satisfaction is an important outcome. So when we put all that together, this is a nice model for improvement that kind of pulls all the things we've been just talking about into one nice model for improvement. It starts with asking 3 questions. What are we trying to accomplish? This is known as the aim. Second, how will we know that a change is actually an improvement? This is where measurement is critical. Unless you measure whether or not you've made a change, you're not going to know if it's been an improvement. And finally, what change can we make that will result in improvement? And that's the change we're really interested in. And so these 3 questions, combined with the Plan, Do, Study, Act cycle, can lead to improvements and is something that all residents and fellows should understand how to do and should get some experience in actually applying in their own practice. I just want to emphasize this again. I feel like I might be beating a bit of a dead horse here, but I hope that you now realize that data is absolutely essential in quality improvement. Without quality data, you cannot effectively complete an accurate needs assessment, what's working or not working within your microsystem. You can't measure change. You can't develop individual action plans that you need. And finally, you can't change systems to improve care and resident education programs. You have to have data. So with that in mind, I want to provide an actual case example about why data is so critical. The Macy Care of the Vulnerable Elderly Study, or COVE, was funded by the Josiah Macy Foundation and the ABIM Foundation to assess the impact of a particular web-based tool called the COVE PIM to see whether or not it can improve the knowledge, skills, and attitudes of trainees in the care of specific geriatric conditions, and also whether or not it could lead to changes in trainee attitudes about geriatric care guidelines, practice-based learning and improvement, and systems-based practice. But perhaps most importantly, it was also designed to see if it could improve the quality of care of elderly patients being seen and taken care of in residency settings. The benchmarks for the care of the elderly study were originally developed for our maintenance of certification program and has been used by a number of practicing physicians. Data from 144 practicing physicians who elected to complete the COVE PIM, and you can see there that it broke down to roughly half geriatrician and half other specialties. The data I'm about to show you come from 52 residency clinic sites, representing roughly 2,200 patients, compared against about 3,700 patients from these 144 practicing physicians. As you can see from the slide, in the column labeled resident clinic, the mean performance shown in red was quite low compared to the practicing physicians. In fact, only one of these performance quality measures attained a compliance or adherence level of 40%. Almost all of them were below 30% compliance. What does that mean? It means that over 7 in 10 patients seen in the residency clinics did not get the important geriatric process of care that they needed in these training clinics.